Now we will move to our second lecture tonight, Diabetic Ketoacidosis with Dr. Amr Hany Safwat. Dr. Amr is a consultant anesthesia and intensive care medicine, Naser City Insurance Hospital in Cairo. Dr. Amr, the mic is yours.
Okay, thank you so much. First of all, I would like to thank everyone for Dr. Saad and the faculty for inviting me again to give this interesting lecture in this course. I was honored by this invitation. And the second thing I want to say, it will be an extremely difficult task to give a lecture after all this informative talk with Dr. Muhammad. He gave us a lot of information and a lot of important topics. So I hope that there is still place in the minds of the listeners to my lecture. So today we'll be talking about a topic that can be usually seen in our everyday practice. It's an important topic. It's a big topic. I try to summarize as much as possible to make it clear for people who are having exams or going for exams, and for people practicing in the ICU or the OR every day. Diabetic ketoacidosis is a major life-threatening complication of diabetes. It happens due to absolute or relative insulin deficiency, leading to failure of glucose uptake. Liver breaks down fats into ketones to employ it as a fuel source. So, from the name, diabetic ketoacidosis, DKA. D for diabetes with blood glucose above 15 millimole per liter. K, ketones are positive in serum or urine. A, it shows acidosis with arterial capillary pH below 7.3, with serum bicarb less than 18 and a high anion gap. DKA occurs in about 14% of all hospital admissions of patients with diabetes mellitus. It represents 16% of all diabetes mellitus related fatalities, and it occurs primarily in type 1 DM, with roughly 2 episodes in about 100 patients per year. And it can present the initial presentation of type 1 diabetes mellitus. DKA also can occur with type 2 diabetes mellitus in cases of severe physiological stress. With type 1, usually we see it as in patients with failure to take insulin, as lack of patient education, physiological stress, excessive alcohol intake, or mechanical failure of insulin pump. Infections like UTI and pneumonia, where Klebsiella pneumonia is the most common DKA-associated pneumonia, and medical or surgical stress. With type 2 diabetes mellitus, it can happen with intercurrent illnesses plus diabetes like acute MI, pneumonia, and some medications such as steroids, thiazides, and sympathomimetics. What is the pathophysiology of DKA? It's the result of a complex metabolic derangement caused by absolute or relative insulin deficiency and increased level of counter-regulatory hormones like glucagon, cortisol, epinephrine, and growth hormone. The metabolic imbalance enhances hepatic gluconeogenesis, glycogenolysis, and lipolysis. Insulin deficiency will decrease glucose uptake, causing hyperglycemia and osmotic diuresis, leading to dehydration up to 100 milliliter per kilogram, and it might cause severe electrolyte disturbance. Proteolysis, amino acid deficiency, leading to gluconeogenesis and glycogenolysis. Lipolysis will lead to increased glycerol, which increases amino acids, and increased free fatty acids, causing ketogenesis and acidosis. How usually the presentation of DKA? Usually the patient will come with history of missed insulin dose and giving symptoms of insidious polyuria, polydipsia are the most common early symptoms of DKA. Nausea and vomiting, decreased appetite, anorexia, altered consciousness, abdominal pains, and it is sometimes called one of the medical causes of acute abdomen. Symptoms of the original pathology as fever, chest pain, etc., etc. What signs I would see? The patient will look ill appearance with signs of dehydration, dry skin, dry mucous membranes, decrease in skin turgor, tachypnea with characteristic acetone breath odor, tachycardia, hypotension, fever. What will be the differential diagnosis that we can think about in cases of DKA? Number one, we can think of acute pancreatitis, alcoholic ketoacidosis, lactic acidosis, salicylate toxicity, sepsis, and septic shock. If we are facing a case of suspected DKA, what would be the workup to be done in such cases? We will have some lab tests. Blood glucose levels should be tested every 1 to 2 hours until patient is stable, then every 4 to 6 hours. Serum electrolyte panel, it should be repeated every 1 to 2 hours until the patient is stable, then again 4 to 6 hours. Initial serum potassium could be high due to extracellular shift of potassium. That's why it should be reassessed. Serum sodium levels are usually low, as every 100 milligram of glucose can decrease serum sodium 1.6 milliequivalent per liter. These are the lab values that we can see associated with DKA: high glucose, low pH, high anion gap, low sodium bicarb. In the urine analysis, I will see ketones and glucose, serum creatinine usually elevated, patient dehydrated, serum sodium elevated or normal, serum potassium elevated or normal, serum phosphate elevated or normal, and white blood cell count can be mildly elevated. In the arterial blood gases done, I will see a typical picture of metabolic acidosis with low pH and low bicarb with a high anion gap. Venous blood can be used also for the analysis, because I'm not really checking for the oxygen, I'm checking for the pH and electrolytes. The anion gap will be above 10 to 12 in mild DKA cases, and it will be above 12 if severe. I will check serum amylase, CBC, RFT, serum calcium, magnesium, and phosphorus. Serum ketones can be checked also. It will be mostly beta hydroxybutyrate level can be measured and gives a good idea about the progress of treatment. Levels above 3 milligram per deciliter are considered abnormal. Beta hydroxybutyrate levels may not normalize during the first 24 to 48 hours of treatment. In the urine dipsticks, it should be done to follow up glucose and ketone levels. Investigation to determine the cause of DKA. What is the triggering factor of DKA? I will make blood and urine culture in case of infection, chest X-ray to exclude pneumonia, ECG and serum troponin for suspected cases of MI, CT brain in cases of affected consciousness. This is how to diagnose the severity of DKA. We are talking about the serum glucose level, arterial pH, serum bicarb, urine ketones, serum ketones, anion gap, and the mental status. They can divide DKA as mild, moderate, or severe. What are the complications that happen in DKA? DKA can lead to many complications which can be life-threatening, and the most dangerous complication that we can meet is cerebral edema. It is the most common cause of DKA-related mortality, especially in children and adolescents. Cerebral edema usually results from rapid intracellular fluid shifts. That's why we have to be cautious in our correction of volume, status, and electrolytes. Acute pulmonary edema can occur due to overcorrection, especially in elderly patients. Thrombosis and embolism, and acute renal injury can happen from the severe dehydration and decreased fluid status. What are my goals in the management of DKA? Again, DKA, I will treat the D, I'll treat the dehydration and the diabetes, I'll treat the K, I'll treat the ketosis and acidosis, I'll treat the A, the abnormal electrolytes and causes of DKA. So we'll take step by step our management. This is an important algorithm of how to start your treatment and how to progress according to the pH, the level of potassium, the dehydration status, and how to control blood glucose and when to shift the insulin to regular insulin and when to go for other fluids like glucose insulin or less. How to treat? Managing DKA in high dependency unit of ICU during the first 24 to 48 hours is advised. First, I will correct the fluid loss. IV fluid will replace extravascular and intravascular fluid and electrolyte losses and maintain urine output. It will dilute both glucose level and level of circulating counter-regulatory hormones. So giving IV fluids will decrease the levels of glucose and regulatory hormones concentration. It will improve the condition. Start with isotonic sodium chloride solution, a bolus dose of 20-25 milliliter per kilogram. Then the choice of fluid for further depletion depends upon the hydration status, serum electrolytes, and urine output. In patients who are eunatremic or hypernatremic, use of half isotonic saline 0.45 at the rate of 5-15 milliliter per kilogram per hour. In hyponatremic patients, the use of isotonic saline in the same rate. Aim is to replace half of the fluid deficit in the first 12 to 24 hours according to the patient's condition. Some centers recommend the use of balanced electrolyte solution to avoid development of hyperchloromic acidosis. And when RBS decreased to less than 200, and in some centers they are talking about 250, change the IV fluid to dextrose with half normal saline. Insulin therapy during cases of DKA. The optimal rate of glucose reduction is 50 to 70 milligram per hour. Bolus dose of 0.1 unit per kilogram, body weight of short-acting insulin, then continuous infusion of 0.1 unit per kilogram per hour. When the plasma glucose reaches 200 mg, insulin rate should be decreased to 0.05 unit with a change of IV fluid to dextrose 5% in half isotonic saline. The rate of insulin infusion should be adjusted to maintain the blood glucose between 150 and 180. Patients are not usually discharged from the hospital unless they are already back to their daily insulin regimen without recurrence of ketosis. If patient is stable with pH above 7.3, bicarb above 18, patients are allowed to eat a meal preceded by subcutaneous dose of regular insulin with 0.5 to 0.8 unit per kilogram, and insulin infusion should be stopped 30 minutes later. How to correct electrolyte abnormalities? Although total body potassium is depleted, mild to moderate hyperkalemia is there due to acidosis and decrease of insulin. So, insulin, if you start insulin therapy and correction of acidosis, volume expansion, it will further decrease the serum potassium. So, to prevent hyperkalemia, potassium replacement is started if potassium falls below 5.3 milliequivalent, adding 20 to 30 millimole potassium to each liter of IV fluid as sufficient to keep serum potassium between 4 to 5 milliequivalent per liter. Stop potassium replacement when serum potassium is 5.5. Now it's advised to delay insulin therapy until potassium is at least above 3.5. So if during the start of our treatment, potassium is low, try to correct it to reach 3.5 before starting insulin therapy. Treatment of acidosis. Patient with pH above 7, insulin therapy, volume correction, and inhibition of lipolysis will correct the acidosis. Patient with severe DKA with bicarb less than 10, PCO2 less than 12 may experience deterioration if not treated with bicarb. So patient with pH 6.9 to 7, 50 millimoles of sodium bicarb and 10 millimoles of potassium chloride over 2 hours to maintain the pH above 7. If pH 6.9 or less, 100 millimole of sodium bicarb with potassium chloride, and venous pH should be assessed at least every 2 hours to check the prognosis of my treatment. Alongside with treatment of DKA, I have to try to find and treat the cause of DKA, like infection, like CVA, like acute MI. What's the prognosis of cases of DKA? The overall mortality is between 0.2 and 2%. Deep coma, hypothermia, and oliguria are signs of poor prognosis. The worst prognosis observed in older patients with severe intercurrent illness like MI, sepsis, or pneumonia. When DKA is treated properly, it rarely produces residual effects, and cerebral edema remains the most common cause of mortality. This is a very concise talk about the DKA. Thank you so much. And I hope that it was beneficial to everyone.
Thank you, Dr. Amr, for this nice presentation. And
very short.
Thank you so much. And we are waiting our audience if there is any question. I just would like to stress in some points, Dr. Amr, don't start insulin therapy before fluid resuscitation or before rehydrating the patient. This is the first point.
Yes, that's true.
Yeah, and the second one is don't start also insulin therapy. And I think you mentioned in your presentation if the potassium level below 3.5 millimole. Yes.
Yes, that's true.
Yeah. We are still waiting our audience. I think we don't have any question. So at the end of this webinar tonight, I would like to thank Dr. Muhammad and Dr. Amr for the nice presentation and informative lectures tonight. Thank you, our audience, to join us.